Dr. Padidela will speak to us today on the management of hypophosphatemic rickets. Over to you, Dr. Padidela.
Thank you very much for your kind words. I'm just going to first share my screen. I'm just struggling to find my presentation here.
Sir, open the PPT somewhere, or don't.
Yeah, it's showing different.
Have you opened it?
Yeah, it is open on my computer. So let me just.
Then you go to that share content. Then you will see your PPT. It will show the desktop, Windows, PPT, everything. It will show you. Go to that share content button. That is small square upper arrow.
Yeah, no, I've gone there. I have the presentation.
There you click.
Here,
then you see the PPT.
Open from here.
And click on double click on that one, on your PPT.
Okay. Yeah, I've got it now.
Yeah, double click it. Yeah.
Can you see this now?
Yeah. Then you go to this one, sir. Yeah, correct.
Okay. Yeah, we finally got it. So thank you very much for your kind word, Professor Bhatia. So I'm going to present on management of hypophosphatemic rickets. All rickets, almost all of them except for hypophosphatasia, is because of hypophosphatemia. But I'm going to mainly discuss the hereditary forms of hypophosphatemic rickets. So this is overview of my presentation. So I will be presenting initially on phosphate homeostasis, then FGF23 and phosphate wasting disorders. X-linked hypophosphatemic rickets is one of the most common cause of hereditary forms of hypophosphatemic rickets. So I'll discuss management. And then finally, I'll end with renal tubular disorders causing hypophosphatemia. So to start with regulation of serum phosphate concentration, for any mineral, there has to be a balance between absorption and urinary excretion. With phosphate, there is active absorption, which is happening mediated by 1,25-dihydroxyvitamin D. And then there is a passive absorption, which is in favor of the concentration gradient based on the dietary intake of phosphate. Urinary excretion of phosphate is mediated through two hormones. One is a parathyroid hormone, and the other one is FGF23. So with regards to absorption, it is mediated through 1,25-dihydroxyvitamin D, which stimulates the formation of sodium phosphate cotransporter 2B, which then allows active absorption of phosphate from the diet which one takes. There is also passive absorption, which occurs from paracellular membrane, and this is dependent on the concentration gradient. Higher concentration gradient will allow phosphate to be absorbed through passive process. With regards to phosphate absorption, it is different from calcium absorption in a sense that dietary phosphate deficiency is unlikely because the food we eat is abundant in natural sources of phosphate. Phosphate is an intracellular mineral, and any organic matter which one consumes, there is abundance of phosphate. Unlike calcium, calcium deficiency is not uncommon, but it is extremely rare to have phosphate deficiency. It does develop in cases of extreme starvation, especially with refeeding syndrome when there is insulin secretion, or if there's a lot of phosphate binders. Special formula feeds have been described which causes hypophosphatemia. And the most common cause of low phosphate is renal phosphate wasting because it is very rare to have dietary phosphate absorption defect. Hormonal regulation of phosphate absorption from small intestine, which is by 1,25-dihydroxy, therefore plays a minor role in phosphate homeostasis. So the balance is very much tilted towards what exactly happens with urinary excretion. So therefore, if there is problems with parathyroid hormone, which can happen with calcium deficiency state, or if there is excess FGF23 secretion, then there is increased excretion of phosphate. Now, looking at how phosphate is absorbed, so this is the glomerular filtrate, this is the renal tubular cells, and what exactly happens is that there are NAPI2A and NAPI2C co-transporters here. So I discussed about NAPI2B in the gut, and here we have NAPI2A and NAPI2C co-transporters. And what they do is that they naturally reabsorb calcium from the phosphate from the glomerular filtrate, and this is then transported into the blood. So this is how phosphate is constantly reabsorbed from the glomerular filtrate, and phosphate, sorry, if I said calcium, it's phosphate. Phosphate concentration is maintained. What FGF23 does is that it binds to the FGF receptor, and this FGF receptor is not selective to FGF23 alone. It can bind to other FGFs as well. But in the presence of clotho, it becomes quite active. And what it does is that it downregulates NAPI2A and NAPI2 co-transporters. And therefore, there is no way these phosphate can be reabsorbed from the glomerular filtrate, and therefore there is loss of phosphate. So excess FGF23 facilitates excretion of phosphate in the urine. What it also does is that it inhibits 1-alpha hydroxylase activity, which reduces 1,25-dihydroxyvitamin D concentration, which further reduces phosphate absorption. It stimulates metabolism of 1,25-dihydroxyvitamin D, further reducing its concentration. A combination of increased excretion of phosphate in the urine and reduced 1,25-dihydroxy concentration reduces serum phosphate. But since I have discussed with you that dietary phosphate absorption is more passive than active, it's urinary excretion of phosphate which becomes more important with FGF23. Now, with regards to FGF23 and phosphate wasting disorder, there are a number of conditions which leads to hypophosphatemia. In all cases, it is because of increased excretion of phosphate in the urine. All these conditions, there is increase in FGF23 concentration, except for hereditary hypophosphatemic rickets with hypercalciuria, which Chetan just presented. So this is one condition where FGF23 is low, but phosphate is low because of increased urinary excretion. Now, I'll focus mainly on X-linked hypophosphatemic rickets because this is the most common genetic cause of hypophosphatemia. And this in children causes rickets and osteomalacia. And because of rickets and osteomalacia, these children develop bone deformities. It could be, it is mainly genu-varum, but it can be genu-valgum as well. Most children, despite starting treatment, develop a varying degree of short stature. These children also can develop dental abscess and very rare complication of cranial synostosis and raised intracranial pressure. So the standard treatment of X-linked hypophosphatemic rickets is with oral phosphate and active vitamin D. Disease pathogenesis is high FGF23, which increases urinary excretion of phosphate, which reduces serum phosphate, causing rickets. So the logical thing is to give oral phosphate, which would help in healing of rickets. But there are challenges in managing this condition. Phosphate is rapidly absorbed. Our gut is like a sponge for phosphate. Whatever you give it, it just sucks it in. And it is rapidly excreted because there is high FGF23. So therefore, frequent dosing is required. The other problem with phosphate is that as soon as phosphate is taken, there is a rapid increase in serum phosphate concentration, which reduces ionized calcium, which increases parathyroid hormone concentration, and that can cause secondary hyperparathyroidism if this is not monitored. The other problem we have with oral phosphate supplementation is that as soon as the phosphate concentration goes up, FGF23 concentration goes up further, which further inhibits 1,25-dihydroxyvitamin D, and it is required for healing of rickets. So alpha-calcidol or calcitriol is important for management because it suppresses parathyroid hormone secretion, keeps parathyroid hormone within the normal range, preventing secondary hyperparathyroidism or tertiary hyperparathyroidism. But the problem here is that if active vitamin D is given, there can be increased urinary calcium excretion, and in combination with increased urinary phosphate excretion, there is nephrocalcinosis. So there is science behind management with oral phosphate and alpha-calcidol, but then later on it becomes more about art of how we juggle both the medication to allow healing of rickets and to prevent development of nephrocalcinosis. Burosumab is a monoclonal antibody, and what it does is that it binds with FGF23 and reduces its effect. And therefore, there is increase in expression of NaPi2A and NaPi2C cotransporters, which reduces phosphate excretion. And in addition, it also increases concentration of 1,25-dihydroxyvitamin D, which also contributes towards phosphate absorption, and it increases serum phosphate concentration by preventing the effect of FGF23 on tubules, and therefore phosphate is reabsorbed from the glomerular filtrate. And this is one of the studies in which I was involved in the phase 3 trial, where Burosumab was compared with conventional therapy. And here you would see that those who were given oral phosphate and alpha-calcidol, they continue to have phosphate below the normal range throughout, whereas those who received Burosumab, there was increase in phosphate concentration and it remained above the normal range throughout the duration of the trial. And this was possible because there was increase in TMP-GFR compared to conventional therapy. In conventional therapy, TMP-GFR did not change and the phosphate concentration continued to remain low. And this is an example of one of the patients in the clinical trial where there is rickets at baseline, and this patient was treated with conventional therapy for more than 2 years. And within 40 weeks, the rickets severity score decreased from 3.5 to 1.5, and you can see that there are significant changes suggesting healing of rickets. And in most patients, this healing of rickets has continued to improve beyond 64 weeks, and we have also observed them in clinical practice. Deformities, once they develop, they are very slow to improve, but this definitely prevents the development of deformities. Now, with regards to conventional therapy, which is again one of the most commonly used therapy throughout the world, it is successful in normalizing. It is successful in healing rickets, but it is important that successful treatment does not mean that we normalize serum phosphate. If one is trying to normalize serum phosphate, we are giving really toxic doses, because whatever phosphate we give, it completely excreted very quickly. And if one tries to normalize, the doses are going to be very high, and that will be very toxic. So if one tries to normalize serum phosphate, that will lead to overtreatment, secondary hyperparathyroidism, and tertiary hyperparathyroidism as well. So in conventional therapy, it is possible to normalize alkaline phosphatase or keep it near normal. And therefore, this is one of the important biomarkers we look at when we are managing patients with XLH with conventional therapy. The other important biomarker is parathyroid hormone, to make sure that it is not high, as that means that there is secondary hyperparathyroidism, and also measure urine calcium creatine ratio. The way we tend to do this, we used to do this, is to monitor frequently. The frequency of monitoring is much higher during growing age, for example, during infancy and puberty, and less frequent requirement of monitoring and changing of doses during childhood and adulthood. It's also important to monitor for nephrocalcinosis, and we used to do ultrasound scanning once a year when we were managing patients on conventional therapy. This is an example of how I titrated doses using conventional therapy. So this is a 6-year-old boy, very good management by mum. Mum had quite significant X-linked hypophosphatemic rickets, and she didn't manage it very well, but she realized that, and she makes sure that her son is managed as well as we can. So at 6 years, when I saw him, he was on 1 microgram of alpha calcidol. His his phosphorus dose was 45 milligrams per kg per day, and alkaline phosphatase was high, and this was a recent increase. Parathyroid hormone was normal, urine calcium creatinine excretion was normal. And what I did was that I increased the dose of phosphate because I would like to make sure that this alkaline phosphatase doesn't go up any further, and whatever rickets has worsened will heal. So I increased the phosphate, but when I increase the phosphate, I'm very well aware that there is a potential for parathyroid hormone to go up. So what I did was I also increased alpha calcidol to 1.1 micrograms. So repeat bloods in 3 months' time on 55 milligrams per kg per day of phosphate. What I found was that alkaline phosphatase was decreasing. It's not yet normal, but it is decreasing, which is good news. But this phosphorus dose has increased parathyroid hormone concentration. That means that I will have to give alpha calcidol. So I increase the dose of alpha calcidol. And a subsequent blood test again in 3 to 4 months shows that alkaline phosphatase has further reduced. Parathyroid hormone concentration has reduced, and it is within the normal range. And as you can see, that as soon as I've increased alpha calcidol, there is a bit of an increase in urinary excretion of calcium, but it is still within the normal range. So the plan is to continue on current dose. If we manage patient this intensively, nephrocalcinosis can develop. Because the alpha calcidol dose and the higher phosphate doses does cause increase in urinary calcium and phosphate excretion. And if the ricket is healed well, what I tend to do is reduce both alpha calcidol as well as phosphorus, provided alkaline phosphatase is within the normal range. On some occasion, it's very hard to normalize PTH with alpha calcidol alone. So if you reduce the phosphorus dose, rickets doesn't heal, but if you increase the phosphorus dose, PTH increases, and it is difficult to reduce with alpha calcidol alone. And in such cases, I had to use cinacalcet, and it works. It does reduce parathyroid hormone concentration, but it's important to make sure that once we're giving cinacalcet, calcium is not going down, because there is a potential for it to go down. So when it comes to biochemical markers for monitoring treatment in XLH, do not use serum phosphate for adjustment of dose. It's mainly alkaline phosphatase, parathyroid hormone, and urine calcium creatinine ratio. Whereas with Burosumab, it's different. It is mainly looking at serum phosphatase as well as alkaline phosphatase to adjust the dose of Burosumab. We do look into parathyroid hormone, especially to make sure that they are not calcium and vitamin D deficient, because if they are calcium and vitamin D deficient, PTH goes up, and then that reduces serum phosphate concentration. And we do, on occasion, check TMP-GFR. So serum phosphate should not be used in conventional therapy for monitoring treatment, but for Burosumab, it is important that one looks into serum phosphate concentration. Again, when you're looking at serum phosphate concentration, one should have age-specific normal ranges. It's not uncommon for some of the labs to give adult values as reference ranges, and if one were to use that, we will be in difficulty in not only misdiagnosing hypophosphatemia, but not appropriately managing them, especially when it comes to Burosumab treatment. I've given this in millimoles per liter because that's what we use, but you can very well have milligrams per deciliter ranges available from your lab. So with Burosumab treatment, this is one of my patients who was in clinical trial and then continued taking Burosumab treatment. So pre-treatment, there is this ricketic changes. Typically, it tends to involve more on the medial condyle, as you will see there. And with treatment, Burosumab, there was a significant improvement, and this continued to remain so. And there was improvement in deformity. And this is a girl, 1 year, 10 months pre-treatment, there's bowing of legs, and there are ricketic changes. There was a significant waddling gait. And as you would see at 3 years, 4 months, there is significant healing of rickets, and the bowing deformity has also significantly improved. I'm not going to go in much details about how we titrate the dose of Burosumab, because I don't think it's just readily available in the Indian subcontinent. I'm not sure if it's been licensed. Generally, this is a publication which we recently put in about guidance on using Burosumab in treatment of XLH, where we start with 0.4 milligrams per kg and then slowly increase the dose based on serum phosphate concentration as well as alkaline phosphatase concentration. So we discussed about X-linked hypophosphatemic rickets, and all these conditions, they are FGF23 mediated. And in all these conditions, the treatment would be with alpha-calcidol and oral phosphate supplementation. For example, McCune-Albright syndrome. It is not uncommon for patients who have got severe fibrous dysplasia lesions to have hypophosphatemia, and we tend to monitor them very closely every 6 monthly by doing fasting phosphate sample. And it's very important to do fasting in these ones because milder severity may be missed, and also looking at TMP-GFR. So in all conditions where there is excess FGF23, the treatment would remain same with alpha-calcidol and oral phosphate supplementation, except for a condition which is because of mutation in SLC34A3. Here, it's different. Here they have, because of the mutation, there is reduced NAPI2C co-transporters, and therefore there is a excretion of phosphate in the urine. But what happens when the phosphate is excreted in the urine is that there is a reduction in serum phosphate concentration, which then reduces FGF23 concentration. So you have decreased serum phosphate, which causes hypophosphatemic rickets, as Chetan presented. But this just says serum phosphate concentration actually reduces FGF23 concentration, because when the serum phosphate is high, FGF23 is high. When the serum phosphate is low, FGF23 is low. That then increases 1-alpha hydroxylase activity, causing hypercalciuria. And the treatment is with oral phosphate and not with active vitamin D. So any patient who comes to us with hypophosphatemic rickets, if there is no family history, we try to find out why the phosphate is low. Again, FGF23 is not something we routinely measure. It's probably easier for us to do a genetic testing of a panel of hypophosphatemic rickets than to measure FGF23. So we tend to do that and then start the patients on both oral phosphate and alpha-calcidol if it is XLH or FGF23 mediated. But if there is hypophosphatemic rickets because of mutation in this gene, then we don't tend to give active vitamin D. And the reason for that is because when there is mutation, when there is reduction of NAPI2C co-transporter, there is reduction in FGF23, there is excretion of phosphate in the urine, there is reduction in FGF23 concentration, and what it does is then increases excretion of calcium in the urine, and therefore there is nephrocalcinosis and renal stone. So therefore one should be very careful about diagnosis before starting treatment. I will briefly go and mention renal tubular disorder, and Chetan has covered quite a bit of it and made my work easy. So proximal renal tubular acidosis with Fanconi syndrome, there's lots of solutes, mainly reclaimed in the proximal renal tubule. So one tends to see metabolic acidosis, hypocalcemia, hypokalemia, hypophosphatemia, there is glycosuria, hypercalciuria, and there could be aminoaciduria. And they do develop hypophosphatemic rickets and growth retardation. There are inherited syndromes, so you will see quite a few disorders which cause Fanconi syndrome. So there's cystinosis, mitochondrial disorder, Dent's disease, and then there are other hereditary disorders, metabolic, and then there is Wilson's disease. And what I tend to do is that these patients with these conditions tend to remain with their primary physicians, for example, mitochondrial disorder, Fanconi Bickel, hereditary fructose intolerance. They tend to stay with the metabolic team, dense and cystinosis with the renal team, Wilson's with the liver team, and I advise them on management of this condition, making sure that phosphate is adequate to heal rickets, but not to excess to stimulate PTH secretion. And then one needs to look into drug-induced, and the common one is the valproic acid. So I'm going to present this case. He's a 10-year-old with severe genu-valgum, and it's very rare for this to happen in UK, that suddenly you have a 10-year-old boy who presents with this massive genu-valgum. And it so happened that one of our local district general hospital consultant called me, I've got a boy with severe genu-valgum. It is so bad that he's almost walking on his knees. And I took these photographs, but I have to say that this doesn't really show the severity of his genu-valgum. One need to really see him walking to see how significant his genu-valgum was. And the reason he was picked up so late was just a few weeks ago. He just arrived from Spain. He's a Pakistani origin patient, parents consanguineous. And you could see that he had enlarged wrist and the double malleolar. So basically, he had severe rickets. And in Spain, he was being managed with oral calcium alone. And that's what we got the history. Parents didn't bring any documentation there for us to read through. So this is what she presented. This was the story. These were the images, and what she did was she did investigations, radiology, and I could look into those in the system, and you could clearly see that there are quite severe ricketic changes at the wrist area and at a knee as well. So this child has got severe rickets, and the first thing which comes to mind is, could this be nutritional, because that's very common, and the other ones which tend to see is vitamin D dependent rickets, type 1, type 2 is quite rare, so I was thinking, was it type 1? So I asked what would be the biochemistry, and the first thing she said was that adjusted calcium is 2.39. It's generally, if it is vitamin D dependent type 2, we tend to see hypocalcemia. Type 1 as well can present with hypocalcemia. So I was thinking, maybe not, but could this be nutritional rickets, severe vitamin D or calcium deficiency? Phosphate was low, so that doesn't help really, because this could be PTH mediated. So PTH could be high in calcipenic rickets, so that could be excreting phosphate in the urine. Alkaline phosphatase is a bit high, but generally with the severity of rickets he has, I would have thought that alkaline phosphatase would be much higher if it is calcipenic rickets, but really I can't comment on that and say that that definitely should be the case. But what was interesting was that the parathyroid hormone was completely normal, and straight away I spoke to our renal colleague and said, look, this child, we haven't investigated, I haven't seen him, but it's likely to be tubulopathy. Would we bring him to the hospital in our tertiary center under you and then manage? And they said, yeah, that's absolutely fine. So this patient was brought in to our tertiary unit under the renal team, and we saw that the potassium was low, bicarbonate was low, anti-PGFR was very low, and again, this TMP-GFR, if it was a nutritional ricket, it would be low, and that would be because the PTH is driving phosphate excretion. But here TMP-GFR is low because of the tubules leaking phosphate. And also you can see that there is an increase in the calcium creatinine ratio. Did ultrasound scan, and not surprisingly, there were features of nephrocalcinosis. And this child has hypothyroidism, so we thought this looks very much like cystinosis. But unfortunately, ophthalmological examination was completely normal, so we're waiting for a genetic test to see what is the underlying cause of his severe rickets. So the problem here we have is renal Fanconi syndrome with clinical features of proximal renal tubular acidosis, has got hypokalemia, hypophosphatemia, hyperphosphaturia, predominantly tubular proteinuria, and normal align gap metabolic acidosis, severe hypophosphatemic rickets and short stature, and nephrocalcinosis with hypercalciuria, and also stage 3 kidney disease. And I mentioned has primary hypothyroidism. So we started on potassium citrate. I did stop oral calcium, but his calcium dropped down. So it went low, so I had to restart oral calcium again. But I'm trying to make sure that it's the lowest possible dose, or else there will be increase in nephrocalcinosis. Oral phosphate sandwich, progressively increasing the dose, continues on levothyroxine, and I've made sure that his vitamin D remains within the normal range. So early days, I don't have any further follow-up on this patient. So again, a very similar scenario, tubulopathy, increased phosphate excretion, decrease in serum phosphate, causes reduction in FGF23, increase 125. So again, make sure that it's oral phosphate and not to give active vitamin D. And if there is hypocalciuria causing hypocalcemia, then one needs to make sure that the calcium supplementation is low, not high. Another quick case summary of a patient who is 9 years old, was referred with severe neurodevelopmental delay secondary to congenital disorder of glycosylation. That's the underlying cause. And seizures from birth, so on sodium valproate, and referred for history of fractures. And not uncommon for us to see. We do have a lot of children with disability, wheelchair bound, and this is a common site of fracture at metaphyseal diaphyseal junction in a child who is severely neurodisabled with cerebral palsy or any other metabolic disorder, as was the case here. And we get a lot of referrals. You can see there was a fracture there in the lower end of the tibia a few months ago, and then here at the upper end of at the lower end of the femur there. So was having fractures, and generally we tend to investigate them, and if this is because of disuse osteoporosis, give them a course of bisphosphonate. But it's very important to make sure that we're not missing any other cause of these fractures. And that's what we found in this patient, that his phosphate was low, alkaline phosphatase was high, parathyroid hormone was normal in his case, and we asked the neurology to request vitamin D. Instead, they requested 125 hydroxyvitamin D, which was high, and the TMP-GFR was low. So very clearly, this was looking like a sodium valproate-induced Fanconi, and we did an X-ray which showed rickety changes at rest. Stopped sodium valproate, commenced oral phosphate, and within 9 months, things became normal. So really, this sodium valproate was the one which was causing the tubulopathy and loss of phosphate in the urine here. Okay, that's the final slide. So to summarize, oral phosphate and active vitamin D are effective in management of high FGF23 related phosphate wasting disorder. The challenge is frequent dosing of oral phosphate is required 4 or 5 times a day. Good adherence to treatment is very important. Frequent monitoring of parathyroid hormone, alkaline phosphatase, and urine calcium creatine ratio. These are biomarkers, and I have to say that with good compliance, good monitoring, one should be able to heal rickets and maintain and prevent deformities in XLH. Burosumab has been found to be superior in randomized trial to conventional therapy in management of XLH, but it comes at a huge cost. And it's important to differentiate high FGF23 conditions from disorders of tubular leak. And that's mainly because you would like to give, one should give high doses of oral phosphate, but not active vitamin D, or else there will be nephrocalcinosis and renal stones. Thank you very much for your attention.
Thank you, Dr. Padidela. That was such a nice summing up of a very vast topic. And the last case, valproate, was absolutely stunning. It's such a backbone of therapy. So, we all should be very alert actually from now on. Because all of us see valproate treated children.
Oh, absolutely. I think valproate is commonly seen. I have to say that it's even though it's such a common medication we use, we don't tend to see them. They find the hypophosphatemic rickets associated with sodium valproate, so it's easy to miss this.
Yes. Thank you. The organizers have allowed us to take 2-3 questions from the chat box. So afterwards, I would request you to try to answer
Dr.
some
Noor,
of them in the
Dr.
chat
Noor,
box.
Dr.
Dr.
Noor, can you hear
Padidela,
me?
Dr. Ravi, could you mute yourself, please?
No. I'm talking to you. You have opened two systems, either mobile and that one, that the echoing is occurring. Please close one.
That's for Dr. Noor. Noor Ahmed.
Yeah, for Noor I am telling.
Okay,
Yeah.
now Dr. Padidela. Somebody
Yes.
has asked about surgery for rickets, for deformity in rickets. Would you make a comment?
Yeah, so there are two types of surgeries one can do. One is for correction of genu varum and genu valgum, and that is usually by epiphysiodesis. So we generally tend to do that when they're at a growing age, and generally should be done before or around the time of puberty when the growth is happening. And that is the only surgical procedure we do in X-linked hypophosphatemic rickets during growing period. But they do have rotational deformities, and those rotational deformities, if they are not corrected, we tend to do the osteotomy procedures after they have completed their pubertal growth spurt. But it's important that if one is doing these procedures, the rickets and osteomalacia have healed as well as they could be.
Right. Then there's a question on whether you prefer calcitriol or alpha calcidol, because your slides, yes.
Both are equally good. It's just that we don't have easy availability of calcitriol, and so America and Europe, they use calcitriol that frequently. We tend to use alpha calcidol. What I've been told is that alpha calcidol is once a day, and calcitriol you may have to require to give it twice a day because it's the active form. But there's no difference at all. You can use either of them, and the dose is very similar.
Right. Can oral phosphate be dissolved and stored for like 24 hours or 48 hours?
So some of the families, what they do is that they actually put it in a water bottle, and they constantly give it to the child and make it a habit. So they will put it in a juice and give it, and the whole dose is given spread out throughout the day, and that's feasible. That's absolutely fine. Just need to make sure that it's easily dissolved. There are different preparations available, so one needs to make sure that the one which is tolerated is used. The one which we have, the phosphate sandos which we use, is got very good tolerability, dissolves very well. So we've been fortunate in having it, but I don't think it's available easily in all the countries.
Right. There are some more very nice questions in the chat box, Dr. Padidela, but I'm sorry, I think we have to hand over to the next bunch. So thank you very, very much, and I hope you will come again sometime when Shaila invites you for another session. Thank you very much.
Thank you.
Thank you, sir, for the very lucid presentation. I mean, like, that is a wow and excellent kind of presentation. I would request you to answer the questions that there are plenty of questions in the chat box. I request you to answer some of those questions.
I'll try my best.
Thank you, thank you, sir. Shaila ma'am, would you like to?
It was an excellent presentation. I think there are very interesting questions, and I think they all need the answers. Dr. Raja would definitely take some time in the weekend and answer them. Request from all of us.